Good morning, everyone. Happy Friday to each of you. And on behalf of FATA, welcome to today's webinar titled Ethics and Boundaries for Substance Use Professionals. This webinar is being made available through a collaboration between the Florida Department of Children and Families and FATA. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them using the chat panel. The button to open the chat panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. We will answer questions throughout today's presentation. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the audio connection panel. For computer audio, click the up arrow next to unmute, then click the switch audio connection panel. Click disconnect, click the up arrow and switch audio connection buttons again, then click call in using computer and follow the instructions. If you continue to experience poor audio through your computer, try using the I will call in option. The access code and event password will be posted in the chat panel momentarily. Please note that you must be connected to the audio of this presentation and view it on screen to receive a statement of credit. We are unable to verify attendance if you are not connected to WebEx via your computer or the mobile app. Therefore, phone call only attendees are not eligible for a statement of credit or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through FATA. A statement of credit and CEUs for up to 2 continuing education credits are available for participating in today's webinar. CEUs are available for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. Completing the evaluation is necessary to receive CEUs or to access your statement of credit. Please note that the evaluation will close at the end of the day on Thursday, May 29th, 2025. At the end of today's webinar, you will have 3 opportunities to complete the evaluation: a link posted in the chat, a follow-up email from WebEx, and an automatic web browser pop-up when we end the webinar. To complete the evaluation, you will first need to register or sign into your FATA account. Please ensure that your name and email address match the name and email you used to register with WebEx. Information you provide FATA as part of registering remains confidential. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your license or certification number when you register with our site. If you need assistance with account registration, login information, or accessing the evaluation, fill out a contact form on our website or email training@floridabha.org before May 29th, 2025. Please note that WebEx monitors the arrival and departure times of attendees and provides a report upon completion of the event. We are not permitted to provide a statement of credit if you do not attend the entire webinar, and we are not permitted to provide partial CEUs. Statements of credit will be posted within 30 business days after the evaluation closes in the professional development section of your FATA account. For licensed practitioners, CEUs will be reported to CE Broker within the same time frame. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenter today will be Amanda Marker. Amanda is a licensed mental health counselor. She has worked in behavioral health for 15 years in outpatient clinics, adult and adolescent psychiatric hospitals, and residential treatment centers. Amanda is currently an active member and vice chair on the board of directors for Recovery Epicenter Foundation and is a master instructor for iRise Inc. As an individual with lived experience, Amanda is an advocate for individuals in every stage of recovery. And now I would like to turn it over to our presenter, Amanda Marker.
Good morning, everybody. It's so exciting to see everybody here. I will say, Robert, my computer and all the power went out. I logged back on and now I can't see the PowerPoint. Is everyone else available to see it?
Yes.
You can see it. Okay, perfect, perfect. I have a copy of it up so I can do this blind going through mine. If you would like to just move the page along. So we'll jump right in. About halfway through, we're going to try to take a break and we'll ask some questions at that time. Our learning objectives, we're going to identify unique ethical considerations for working within the substance use and recovery field. We're going to hopefully walk away with at least 3 warning signs that a boundary crossing or an ethical guideline may be compromised, and understand how to develop an action plan and help prevent ethical or boundary crossings and violations in the future. So when you think about the entire spectrum of substance use professionals, this continues to expand and in exciting and really great ways. So we have everything from, this could be your sponsor. That's somebody who is there to perform a mutual aid service, guide someone typically through advice, through lived experience, through scheduled meetings. You have your therapist, your counselor. These substance use professionals will diagnose, they provide counseling, refer to supportive activities, will really focus on problems and issues and utilize a therapeutic modality to help move this client through their recovery journey. You have prescribers, right? So they're going to be also diagnosing, offering medical advice, managing medical prescriptions. You have police, priests, clergy, rabbi, reverends. This is a relationship that can promote particular a religious doctrine or offer forgiveness or provide pastoral counseling. And recently we have peer support, recovery coaches coming in, and certified peer support. All of these are absolutely beautiful supportive roles when it comes to substance use support, treatment, and recovery. And the thing to keep in mind is that all of them don't have the same ethical guidelines, boundaries, and or legal structures in place. So as a substance use counselor, it's our job to promote positive action and morally sound decisions. The client counselor relationship should promote autonomy and stewardship and competence. We're professionals, we're entrusted with aiding those in the need of help, and we should always do our utmost to remain ethical. And all should, however, not all of these positions do have that code of ethics to follow. So if we go by ethical guidelines by profession, so if you think of social workers, mental health counselors, most substance use counselors, we complete specific numbers of hours of training. We have particular degrees, particular licenses. And then unlike social workers, you've got individuals who are certified, they're not licensed, and they may not have the same sanctions stemming from ethical misconduct. Licensed professional counselors who are in recovery themselves also must adhere to ethical codes within their specific field. But we know that a lot of individuals who work in the substance use field are also in recovery and advocates themselves, but this can sometimes make the relationship between the client and the counselor or the client and the professional a little bit blurred. So we're going to definitely dive into that today. We know that vulnerabilities really derive from the heterogeneous pool of workers, where many of whom are not privy to a shared value system, do not belong to a professional organization, and as a result, we're not subject to any specific code of ethics. So if you are attending and you do work in the substance use field, but do not have an ascribed code of ethics, we're going to go through some options where you can look to these places for support or guidance. For example, the NASW, National Association of Social Workers, have a work practice training manual that really outlines the process for working through ethical issues. They practice steps specifically that are suggested, and a conclusion can then move to a rational level of decision making. Professional standards and documents are reflected in all kinds of other resources. So social work, medicine, nursing, psychology, they're all great examples of professions that have standards and codes of ethics that can be used to help guide you. Now, they don't answer every ethical dilemma. That would be nearly impossible, but they do provide parameters for what is allowed or not allowed by their profession. And they also give some guidance towards how to make a decision. In the event that you're saying, I would really love to maybe look at some case examples, you don't have to go far. One thing that you can do is go to the Florida Department of Health, look up disciplinary and administrative actions, open those case files. You can read them, and going through some of them, you'll go like, okay, I could see how that might be a little bit unethical, or holy cow, obviously that's unethical. And we'll get into some of those a little bit later. So why ethics and boundaries matter? It's to protect the therapeutic process. The professional relationship is at its core a fiduciary one. It's not a friendship. It's, even a minor boundary transgression and a minor boundary crossing can really give a mixed message to a vulnerable client and our vulnerable populations. And a boundary symbolizes limits of the professional transaction, and it can protect from liability. We want to make sure that malpractice suits, they attest to this. There is no shortage, and if you do go to the Department of Health and you do look up these disciplinary actions, you don't have to put a huge time range in to have a significant amount of returns, and you'll start to see patterns and trends in what is being considered malpractice and disciplinary actions that are being reported to the board. And we also want to make sure we're protecting our clients from exploitation. Clients are vulnerable. Substance use clients, typically early in recovery or somewhere along that the recovery process, we have to entrust that we're protecting them more than we are potentially causing harm. So inherently, this population is a vulnerable population. So who sets the standards for ethics? National Association for Addiction Professionals, National Certification Commission for Addiction Professionals. These are some really great options to look into. There is a series between the two of them of 9 principles that outline other ethical guidelines for substance use work in areas like confidentiality, professional responsibilities, workplace standards, cultural sensitivity. Despite the comprehensiveness of these codes, there are still ethical dilemmas within substance use treatment that are arising every single day. And with the advancement of technology, and we'll talk about AI in a little bit, there's no shortage of concern of ethical dilemmas. The most recent code of ethics will be released June 1 of this year. And there's an address up there for you to be able to find it. So how does boundaries, ethics, boundary crossing, boundary violations, how does this affect an agency? When an agency experiences ethical dilemmas, that can be really detrimental at the staff level. It can really affect staff morale. We can start to distrust one another. We can start to lose the purpose of why we're in the helping field. It can be associated with high levels of stress and burnout. And when burnout is related to high staff turnover, especially in the substance use disorder realms, and counselors face unique ethical dilemmas, given that many counselors in the field are also in recovery themselves. And so this is a bit of an interesting dual relationship at times, especially if you live maybe in a small rural town. And we'll explore that when we get to dual relationships. So there are principles in the Code of Ethics and the counseling relationship, confidentiality and privileged communication, professional responsibilities and workplace standards, working in a culturally diverse world, assessment, evaluation, and interpretation, and then the use of e-therapy, e-supervision, AI, and social media. And we're going to go through each one of these. Supervision, consultation, addressing ethical concerns, research publication, and then national certified peer support specialists. What is coming up on how we can incorporate peer support into our profession and ensure that there are ethical standards that are being implemented with this organization and these services as well. And then, of course, ethics pertaining to member organizations like your NASW, your national, your APA, those type of things. So in addition to identifying specific ethical standards, there are always additional considerations to follow when making ethical decisions. And this is really counseling ethics specifically, not necessarily substance use, but just counseling in general. We always want to keep in mind the autonomy of our clients, the confidence of our clients, the conscientious refusal, excuse me, I have a hard time saying this word. I can't say this. We want to make sure that we're always helping others. We always want to be not causing any harm. Competence and justice. And, those of us who work in this field, these should not be of any surprise that they are ethical guidelines that should be guiding how we work and interact with our clients. So when we think about your client's autonomy, and there are times that, especially in our substance use realms, some agencies are based on abstinence. Some agencies accept and promote medication-assisted treatment. Some agencies will do a matter of both. Some clinicians have one preference or another. Some people who are clinicians and in recovery will have one preference or another. So how do we respect our clients' autonomy when we know that maybe they're making decisions that we deem are not best for them? One of the things we would do is we would meet our clients where they are, right? We are not meeting our clients where we think they need to be, where we think they should be. We are meeting with them where they are and encouraging their journey for recovery. Therapists and counselors, social workers, we don't give advice. Advice is not part of what we do. We rely on specific theoretical modalities to explore clients' motivations, their thoughts, their behaviors, under the context of a theoretical model with the client. And this may differ based on the substance use professional role. So that is how a therapist or a counselor or clinician may interact with this individual. However, a peer support or a sponsor may have a very different interaction, and they may be giving advice, and they may be saying, well, my personal lived experience has taught me XYZ, or this is where I see, this is what's happening. This doesn't seem to be a best fit for you moving forward. So those boundaries do change, and the conversations can change based on what role you play within that client's recovery journey. So ethical dilemmas, that's a situation where the ethics code for addiction professionals kind of fails to provide clear guidance on an issue, requiring the addiction counselor to make a reasonable decision informed by the code. So unique ethical dilemmas exist in substance use treatment, and it can impact treatment success. For example, if you think about voluntarism, right, or the autonomy to make one's own choice, confidentiality, truth-telling, there's that word again, beneficence. They're There are ethical issues that uniquely occur within the substance use setting, as well as obviously across all treatment settings, but notably decisions around each of these ethical dilemmas could really impact the overall success of your client's treatment. So there's a myriad of dual relationships kind of inherent in the field. And this really includes dilemmas stemming from recovering workers who are attending maybe AA meetings where a client might be, or with their supervisors. There might be a challenging role of some individuals to service providers within the very program with which they were clients, right? So often we see people come through our treatment centers or our programs and they're incredibly successful in their recovery and they've got great support, and now they're going, I want to be a helping professional, and they've done what they've done and now they become a colleague when they were a former client. So that can cause a really interesting dual relationship. Dual relationships are a concern frequently addressed in substance use literature, especially when it comes to ethical and boundary violations. And additional challenges arise, especially if there's increased use of maybe any physical contact in treatment among clients and service providers. That would obviously cause some ethical considerations. If I'm hinging a service to an abstinence theology, could be an ethical consideration. The debates surrounding abstinence versus controlled drinking and harm reduction. Again, these are some ethical considerations that clinicians need to have a stance on. And even, if you think about the needle exchange in general, this is a really clear example of where this can draw a line within your community. It can draw a line within funding, and it can draw a line within community safety and health. So there are ethical considerations far beyond just the individual counselor as well. It can definitely affect a community and access to care and community health as a whole. And ethical dilemmas are typically going to occur because of a conflict between two good things or positive values. So it's really balancing the need to confront an individual directly, maybe about an emerging substance use problem while they're going through a difficult divorce, for example. So you want to make sure that in your sessions, it's honesty, empathy, support, compassion, beneficence, and non-malfeasance. You want to, likewise, like a clinician who is a provider in a court-mandated treatment intervention, or potentially a psychiatrist who performs a pre-transplant evaluation, may be in really difficult positions of influencing the decision of whether maybe your client is facing returning to jail, or maybe your patient is denied a life-saving liver transplant because of ongoing addiction issues and lack of treatment adherence. So there are some situations such as these that really challenge even the self-concept and conscientiousness of the helping professional, of that physician, of that counselor, of that substance use professional, who ultimately want to do good and then now have to make these really life-changing decisions. So there's times, and there's certainly going to be times, where if we find that our compassion for a client situation is starting to wane, or we're frustrated by their actions, certainly that is not a unique experience to just the substance use treatment field, but really all clinicians have probably at some point experienced some sort of compassion fatigue. But for example, let's say that you have a client who is seeing you about a divorce, but you become frustrated by their substance use because it's similar to something that your family did, or it's just really hitting a nerve for you, which is not uncommon in this field. One thing to recommend is just notice your emotions. They are telling you something, right? So it's important to be mindful of those physiological experiences that you're having. It's telling you something, but check them at the door, right? Because these emotions are your own to deal with. in your own therapy, in your own process, right? You got to be really mindful of not bringing your bias into the treatment or into the client sessions. And you don't want to enmesh your emotional responses in with your client's treatment. That can easily lead to boundary crossings. So common professional ethical boundary violations would be inappropriate self-disclosure. So sharing personal information that blurs the line between the counselor and client relationship. Dual relationships, engaging with clients outside of a professional setting, such as a friendship or business dealings. Physical contact, so initiating or allowing physical contact not part of the therapeutic process can create confusion and discomfort and send mixed messages. Accepting or giving gifts, so exchanging gifts with clients may lead to perceived favoritism or obligations. Socializing with clients, so social interactions outside of the therapeutic context can really undermine the professional objectivity when it comes to returning to sessions or structured engagements with these clients. These violations can damage trust, they can harm clients, and result in legal and professional consequences for the counselor or for the substance use professional. Additionally, entering financial or business transactions. So financial dealings with clients can create conflicts of interest and ethical dilemmas. This is definitely a boundary violation. Exploiting the power dynamic, where you're using a client counselor power imbalance for personal gain or manipulation. Failure to maintain confidentiality, so disclosing client information without consent, violating ethical and legal standards, inappropriate emotional involvements, which would be overly emotional involvement in a client can lead to impaired judgment and ineffective therapy. Again, this is really important to keep in mind. These violations can and do damage the trust, they harm clients, and it results in legal and professional consequences for the helping professionals. Now, I would just want to pause here for a second and see if there's any questions about the difference between really an ethical crossing and an ethical boundary violation. Or, are there any questions in the chat so far?
I have not seen any questions come through as of yet, but I do want to give it just a few seconds to see if there are any over the next 10 seconds or so. Somebody did just make the comment that dual relationship issue can be very difficult.
Oh, incredibly, especially, and this is absolutely true. Being myself in recovery, I will see clients who maybe have attended our agency in an AA meeting or an NA meeting, or they'll join a Zoom virtual recovery meeting. And so we're going to get into, especially if you are a substance use professional, how that can impact even your own recovery when it comes to, you've got to set those boundaries and make sure that you are really at all costs protecting that client. So yes, especially in small towns, dual relationships are incredibly difficult. I can tell you, when I was looking at the discipline and administrative actions for LCSWs, LMHCs, and I just picked January through current, and I think there's 38 of them so far. And one of them, it was a really interesting case. There was a counselor who had been renting office space from an individual, and this had gone on for several years. The individual then recommended the counselor to counsel this individual's child. And it was determined that this was unethical because there's an automatic power differential, knowing that there's a financial relationship between the office space owner and the clinician. and then also extending treatment to the child of the owner of the office space. So it was really interesting because that one didn't automatically jump out to me as wildly unethical. And so I kind of had to sit with it for a minute. And you know, of course, it makes sense that there is that power differential. And I think this is a great opportunity to go through these and use them as case examples to say, what do I think about this? Because more oftentimes than not, there is something that's very similar to a situation you're in, or someone else has gone through it, and there is some guidance. This is where supervision comes in. This is where consultation comes in. And absolutely, there are times that a dual relationship is simply unavoidable, especially in small towns. And we're definitely going to get to that. So again, we want to make sure that informed consent is always happening. Oh, I think I just saw a question come up.
The question was, what is considered inappropriate self-disclosure versus appropriate self-disclosure?
Yeah, that's a great question. So there's times when self-disclosure can be appropriate. I think it's important to be mindful of the self-disclosure. Self-disclosure can certainly help build rapport when used sparingly, professionally, and appropriately. The counselor self-disclosure can really build trust, it can foster empathy, it can strengthen a therapeutic alliance between a counselor and a client. However, counselor self-disclosure also really holds the potential to derail progress. It can very easily take the focus off of the client. Personally, I was trained under the theory that everything you say as a clinician in session should serve a purpose. And if it doesn't, then you don't speak for the sake of filling silence. You don't speak for getting your own needs met. So I think before a choice to self-disclose, it's always a good idea to say, why, right? Am I self-disclosing to build rapport, to bridge a topic, to help the client in some way? Or am I self-disclosing to get my own needs met? For example, I would say probably about 6 months ago, I had a client who we were different in every single way you could think. And you could tell he came in, looked at me and said, you know, what am I going to get from you? What, you know, I'm working. He was not working. I'm housed. He was not housed. I am middle-aged white woman. He is an older, retired Black man. The one thing we had in common was that we both have a substance use disorder, right? And so at that point, I made the conscious decision to say, let me tell you, several years ago, I was right where you're sitting. And I know what you're going through. I know this experience. I know my experience of a substance use disorder, my experience of being unhoused because of a substance use disorder. And having that opportunity to find a connection, to build that rapport was really important in that moment. And I ran into him about 2 weekends ago at an event I was at. And he said, I needed you to say that because until you sat down and said, look, I get it. I've been there. I didn't even want to work with you. And so it was in that moment really beneficial. Yes, so I did see a question about an ethical decision-making process. We will do that at the very end. That we're going to talk about ethical concerns, and then we'll talk about how to go through that process and what models to use. You know, how much is too much self-disclosure? You know, that's a fine line. I think that's something, in my opinion, and I don't know that this is factually based or empirically valid, but in my opinion, I think just enough to get that point across, just enough to spur movement or a response from my client. What about self-disclosure as a peer specialist? That's a great example. So that's where our ethical guidelines are different. That's where those boundaries are different. As clinicians, we have ethical guidelines and very set boundaries when it comes to kind of what we should be doing in that relationship. It's a professional relationship. The peer support is a professional relationship as well. However, that is a professional relationship built on shared experience and understanding and being able to share and advise on that shared experience. So I don't see self-disclosure as a peer specialist as potentially harmful as it may be for a clinician or a doctor, just simply based on the purpose of both of those roles. What's the best way to deal with an ethical dilemma? And again, we're going to get to that when we get to our decision-making processes and what models to follow. So we think about informed consent. Addiction professionals, we want to refer clients to appropriate resources when the client's mental, spiritual, physical, or chemical impairment status is beyond the scope of our professional expertise. So we want to make sure that we're fostering self-sufficiency, a healthy self-esteem in others, in relationship with clients, students, employers, supervisors. We really want to strive to develop full creative potential and mature independent functioning of our clients. And some of these services can be provided via technology. We always have to make sure that our clients are fully informed of the limitations and risks associated with these services. Make sure that if you're working with clients over telehealth, let them know that this is my timeline for responding to questions, right? As counselors, or therapists or substance use professionals, we should be having this in our policy. We should be having an idea. If a client comes into your office and says, hey, if I reach out to you via email, do you accept inquiries this way? Do you accept inquiries only over the phone? Can we text? When they ask is not when we should be thinking about what our own boundaries are for this. This is something we should currently have in line. And the counseling relationship. So the addiction professionals, we want to make sure that we're accurate and complete with information regarding the extent of our professional relationship. So we're likely to encounter individuals who are vulnerable and exploitable. We want to make sure that we are protecting those individuals at all costs. So we want to make sure that the relationship that we're building and we want to nurture, we want to support their development and make sure that we're not taking unfair advantage of that. Some of the most alarming discipline and administrative actions that I've read from the Florida state, within the last 12 months rolling, are things that you read and you just get this immediate reaction going, there's just bad apples, right? But I think we're going to talk about that in a little bit and how counselors have boundary violations, especially sexual boundary violations. How could that possibly happen? Confidentiality and privileged communication. So we know that most medical professionals follow the HIPAA guidelines. So the privacy rule, obviously it's established to assure individuals' health information is protected while allowing the flow of health information to relevant individuals and for quality care, for continuity of care. However, all staff of addiction treatment programs and mental health programs must follow a stricter guideline. This is a federal guideline, CFR 42 Part 2. This is a more strict guideline than HIPAA, and it ensures that there are protections for confidentiality of substance use disorder treatment records. So what might you do If a client revokes their ROI and parties are pressuring you to inform, what would you do in this situation? If you were a substance use provider, your client has revoked their ROI, and other parties are pressuring for information, whether that be law enforcement or their primary care provider or their outpatient therapist or their family member. Has anybody been in this situation, and how did you address it? Absolutely. Yeah, we have to honor the client's requests. This is a federal law and it's here for a reason. We have to protect them. Our client is our client, right? Their family member is not our client. Their primary care provider is not our client. Who anybody else needing those records or wanting those records will have to go through the proper chains, because we absolutely have to honor our client's request. So when you think about if a client is on probation, do I need to and they violate it? Do I disclose this? Does this vary if therapy is court ordered? So here is a little vignette that I'd like to go through and just give you what this might look like. So your client arrives for an intensive outpatient program, completes a urinalysis drug screen, which is positive for cocaine. The client swears that they did not use and states the screen must be a false positive. You agree to send the urine out for confirmation and wait to notify collaterals of the positive screen until the confirmation returns. The confirmation comes back, still positive for cocaine. The client is in tears because they do not want their probation officer, psychiatrist, and family to know. You try to work with the client to develop a plan for them to be involved with communicating this news, but they ultimately decide to revoke all releases of information. It's been a week and you have received calls from the parole officer, spouse, and psychiatrist asking for treatment updates. All parties are frustrated. What do you do? And it looks like Mitch stated, I've been in the situation where a client absconded and her mother contacted me. I couldn't tell her anything because there was no ROI. Criminal law supersedes confidentiality. Sort of. Yes, so there are court-ordered disclosures under Regulations Part 2, which is the CFR 42 Part 2. Programs or any person having a legally recognized interest in the disclosure, which is sought, may apply to a court for an order authorizing disclosure of protected patient information. Thus, having a legally recognized interest in the disclosure, which is sought, they can apply for a court order to disclose. That means they're going to have a court order or a subpoena. Even though someone is saying, hey, I work with the courts, can you send this over? That's not sufficient. As a clinician, it is, in my practice, I say I will wait for a subpoena. Obviously, I'm going to be calm and kind and polite and work with anybody who wants to work with me, and I'm going to protect my client. So it says, say there is no authorization to disclose. Yeah, absolutely. Well, that's tricky. If there's no authorization to disclose, you can't confirm or deny that they are even with you. So sometimes that gets a little tricky too. So if I say, oh yeah, I'm with John, I don't have a release for you though. I've already implied that he's in treatment with us. So even having that conversation about how you speak to requests can get tricky. No court order if you are contacted to felony probation treatment. Sure, yeah, so right. So when there are criminal proceedings, there are some extended, I think there are 6 different exclusions under CFR 42 Part 2 when it comes to legal exemptions, which I think in its own could be an entire presentation. So yes, you are right. There are 6 different reasons that, and I believe felony proceedings and immediate danger to self, others, all of those things. There are stipulations. Those I can't speak to as far as 100% certain. If the client is in probation, drug court, or mental health court, isn't disclosure pre-established? So not necessarily, right? So if you think about probation and drug court or mental health court, there's a difference between a court-ordered treatment and a court-recommended treatment. So even though, yes, the judge, magistrate, they may have said, yes, we recommend you seek treatment to have a better outcome in your court case, or they say, yes, you are court ordered, you must complete this treatment before you, resume XYZ. That does not give us carte blanche to release all records. We still need to have a specific release of information to release specific records. All that we would be able to say is, yes, this client is in treatment with us. Not anything about treatment updates, not anything about their, substance use disclosures, or anything regarding to do with what they've disclosed during the treatment. Let's see. In our program, clients have never revoked the releases to the court, which involve probation, although it is an optional program through the court. So we always inform probation for positive tests, and they will proceed once we get confirmation. I feel like that's pretty common as well. So confidentiality, right? All client records and their identity must be secured with extreme care. Because again, anything that has to do with substance use treatment will fall under the federal law, and the federal law does trump HIPAA. So we don't disclose any information regarding a client with anyone outside of the agency without a signed release of information. And we want to caution with family members and other professionals, or even law enforcement, we've got to be really mindful about not breaking confidentiality. Outside of sexual boundary violations, confidentiality breaking is one of the top reported disciplinary actions to the board. So again, we have exceptions to confidentiality. These are really similar when you talk about mental health counseling or substance use counseling. Child abuse, elder abuse, abuse of a vulnerable adult. Of course, these are all things that we're mandated reporters in this situation. Suicidal or homicidal ideations with plan and intent, and victim. Staff communications within a program, within the same agency when it is pertinent to that client's treatment. Crimes committed on program premises or against staff or faculty involving that client. Again, disclosure under special court order. So those could be prearranged, those could be subpoena. And appropriately authorized research, audit, and evaluation, which you do have to have your client consent to if they are a part of a research or evaluation program. And they want to keep in mind our client welfare, right? We want to understand that the ability to do good is based on an underlying concern for the well-being of others. If we act for the good of others and exercise respect and sensitivity and insight, we need to understand that the primary professional responsibility and loyalty is to the welfare of our clients, irrespective of who pays for their fees. This is where families can get really pushy and say, well, I'm paying for their treatment, I need their records, right? And so we will encounter family members, we will encounter individuals who believe that just because they pay for the treatment, they are entitled to those records, and they are not. And right, medical emergency is another one. Absolutely, Dan. Yeah, medical emergency, you can disclose information in the event of a medical emergency. Client self-determination. So we know that chemical dependency counselors, substance use professionals, we've got to understand and respect the fundamental human right of all individuals to self-determination, to make decisions that they consider in their own best interest. So this really reflects what we had talked about earlier. If we don't believe that our client is making the decisions that are best for their life, we still have to meet them where they are. We've got to be open and clear about the nature and extent, effectiveness, cost of treatments and services that we offer. And they need to be able to make an informed decision about their care. So we've got to be able to leave our own biases, our own beliefs at the door. And if a client wants to pursue MAT treatment, or if a client doesn't want to pursue MAT treatment, or we've got to allow that client the self-determination to make choices for their own recovery, because we know that that sticks best. That has the best outcomes, is when a client is feeling empowered to make choices about their own recovery journey. So we talk about boundaries. We want to make every effort to avoid multiple relationships with a client. And this is incredibly hard to do, especially if we live in small towns and rural areas. Oh, I'm sorry, I did just see this. What about insurance companies? We do have to have a release of information from the client to allow us to contact their insurance company to bill for services. That is a pretty common standard form when it comes to a lot of agencies or individual practices. So think about, what about in public places? If you have a client that you see and they come up and they begin to talk to you about a problem, one way to address this is really gently ask them, we've got to wait until we're either in a less public space, or, can this wait until your next appointment? Or, can we go back to the treatment facility and talk about this, or can we schedule an appointment? Then we also want to take the patient or the client's cues about whether to acknowledge one another. I personally have it during one of the first sessions we talk about in public. If I see you in public and you're one of my clients that I'm doing therapy with, I will not acknowledge you unless you acknowledge me first. And I always make that a point to say and have it out there. So I think it's important that you set those expectations early in the counseling relationship, and you set it to what you're obviously most comfortable with and what is best for the client. And obviously you don't want to tell people that you know patients from your facility if you see them in public and you're with your family. Oh, you wouldn't say, oh, that's so-and-so over there. They were my client 3 years ago and look how well they're doing. You would keep that to yourself. But if you think about urban areas as well, it's not just rural areas that struggle with dual relationships and boundaries, because in a rural area, you may have a client who is also your banker. There's no other option because maybe that's the only bank in this town, and it's unavoidable. But again, talking about it with the client and saying, hey, this is a situation, it's unavoidable. This is my idea for navigating it. What do you think about that? And if you think about urban areas as well, it might also be really a similar struggle, especially if you're part of an ethnic minority. If you're a part of a religious community, you may be a part of a very small knit community within a larger urban area. And so you have a smaller circle of common individuals. So, these relationships can include members of maybe your provider's immediate or extended family, business associates from the professional realm, or individuals who have a close personal relationship with the professional or professional's family. It's incredibly hard to avoid, especially in small rural communities, as well as tight-knit specific groups. Let's see, and a couple of comments. I would inform the client at the first meeting about hi and bye if I see them in public. Absolutely. Isn't there a 12-month period after discharging a client where these guidelines aren't imposed? That will vary based on your professional organization membership affiliation. For counseling, mental health counseling, I think it's a 5 to 7 year period. For substance use counseling, sometimes it's infinite, depending on the relationship. You can also have your own boundary. You can say, I never cross this boundary, regardless of whether there is a 12-month period or a 5-year period or a 7-year period. If there isn't one in your professional realm, it's always a good idea to use the National Social Workers ethics, the National, Licensed Mental Health Counselors ethics, Substance Use Treatment Professional ethical guidelines as an example. Best practices number. Yeah, that's kind of my personal theory, but everybody is kind of entitled to do what they think might be right in those situations. I think never as well. Again, really hard in a very, very small town, very rural town where those dual relationships are virtually impossible to avoid. So if you think about recovery counselors who are working in the substance use field, we've got a greater potential to run into former clients when we attend things like 12-step meetings or recovery dharma or celebrate recovery, all of these different options. Again, that's going to be that really small circle, especially in an urban area. So how do we manage this blurred role? Vigilance is required to ensure that we're only providing services within our assigned role and scope of competence. We want to make sure that we're not blurring those lines between professional and friend or banker, and we're not talking about bank business while we're in a therapy session and that type of thing. So without role clarity, the therapeutic relationship is at risk of being really watered down, hurting the local recovery community, creating distrust within the treatment organization. And obviously some roles are more easily defined than others. So if you've got a counselor, psychiatrist, those are pretty structurally defined, right? They have been roles for hundreds of years, decades. Now we talk about recovery coaches and peer specialists, which is in modern history a really relatively new role in recovery that's also being sort of this new professional role. So what does that look like? And those are still a bit ambiguous when it comes to how a peer support or a recovery coach collaborates with individuals in the community or collaborates with treatment professionals and counselors and psychiatrists. So we want to recognize that there are inherent risks and benefits to accepting someone as a client with whom that maybe we've had a prior relationship with. So this can include anyone with whom the provider has had a casual, distant, or past relationship prior to engaging in a counseling relationship with a person from a previous relationship. The provider needs to seek consultation or supervision. The burden is always on the provider to ensure that their judgment is not impaired and that exploitation is not occurring. The burden is always on the provider to prove that. And I think that this would be in the event that there is no other provider that we could possibly refer out to, maybe in one of those rural situations. So what might this look like? You work in an intensive outpatient program and are an active member of your recovery community. A client from the program starts attending your personal recovery home group and begins volunteering. Soon they start to build friendships and ask someone you are close with to be their sponsor. You and your friend typically go out to dinner after this meeting, and now your client is being invited. This meeting and the dinners afterwards are a huge and important part of your recovery program. What do you do in this situation? This is a bit of a personal choice, right? Do I choose to step back from my recovery practices to allow that client to grow and build and be sustaining in that recovery circle? Yeah, tell your friend you prefer a one-on-one dinner. Maybe it is about setting boundaries with your friend. Say, hey, please do not discuss anything with this sponsee that you have. Just out of respect, you know what I do for work. Have a conversation with your client and say, I need to let you know. Yes, you've been attending the programs. Obviously, you've seen me there. But now that you're starting to have a more involved role, you've got to talk about what those boundaries look like. What does it mean? Can you establish an opportunity to still attend while having that professional distance? It's tricky, right? So there's not a clear cut, this is right, this is wrong. And a couple of comments saying, yeah, I would avoid this if possible. And new boundaries, right? So it is okay to revisit the boundaries that you established, especially if things are changing. Try to find a new program, especially in a small area. This happens a lot. Yeah, Linda, that's absolutely true. This does happen a lot. Big cities, small cities, rural, even virtual. You might run into somebody that is a client, and it's a struggle. And I think it's one of the things that, as clinicians and as the professional in the substance use realm, I would find a new place, right? Yes, my recovery is equally as important as my client's recovery. And this is unfortunately an ethical dilemma that we've got to address strictly because of the profession that we chose to go into, right? This was a risk that we knew could have happened. What about a client showing up at church you attend and in a leadership role? Well, that's a really interesting perspective. Yeah, that could certainly happen, right? If you're a part of a congregation and your client shows up, again, I think you have a conversation about how those roles have changed. Do you refer your client to someone else? Is it impacting the client relationship? It is impacting your experience in the congregation. So there are a lot of different perspectives that need to be addressed. You know, are you able to maintain distance and confidentiality in that congregation and not have it affect you? What if I'm the leader of the home group and they show up? Yeah, right. So many different possibilities, right? So if I was the member leading the home group and my client showed up, just like anybody else, I would not acknowledge that I knew them unless they acknowledged first. I would treat them as a first-time comer, like a newcomer to the group if they'd never been there before, as if I didn't know them, because hopefully you've already had this conversation with them that says, if I see you in public, I will not address you unless you address me first. There has been a question here about taking clients to meetings. I have not believed it is okay. I guess that varies, right? It depends on what your role is. Are you the counselor? Are you the psychiatrist? Are you a psychologist? Are you a behavioral health tech? Are you a peer support? Are you a peer coach? Because a peer support, yeah, I absolutely want my peer supports to take my clients to meetings. That's the role. That's what they do. They're in the community to be true peer support, not clinical team members. They're not clinical. And I think we need to be very careful about not trying to put them under the wing of a clinical guideline. Peer supports absolutely need to be going to meetings with clients. That's their job. Clinicians, I wouldn't recommend it, unless it's maybe a meeting on site, right? So say I work at an agency that is maybe a rehab facility and AANA, Smart Recovery, come into the hospital or into the rehab for events, then maybe attend with them as saying, hey, we're going to expose you to what an AA meeting is like, what an NA meeting is like. But then I would also refrain from self-disclosure at that point because you're still under that professional job title. You're at work at that point. I get so many clients that violate their own confidentiality. They will tell whoever, and I'm sitting there looking weird. Yeah, absolutely. Sometimes we just have to look like we've got egg on our face and just go, oh yeah, I do know you. You know, sometimes that happens, but that's their choice, right? That is always their choice to share or not share as much as they want. And you know, there's multiple times in this profession that we get humbled, and sometimes that's it, right? When they kind of make us look ill-willed for not coming back and saying hello when they announce, oh hey, that's my therapist. It can definitely be uncomfortable sometimes. Doesn't that violate their privacy? I don't know if I follow what that was in response to. So when we talk about multiple relationships, we want to avoid if possible. If unavoidable, take precautions. Remember, it is on the provider to always prove that no exploitation is happening, that provider judgment is not being affected. You've got to disclose and process and supervision. That's what supervision and consultation are for. You know, we don't have to figure out everything on our own. That's why we have peers, and that's why we have colleagues, and that's why we have supervision and consultation groups. You know, they're there for a reason. We've got to openly discuss it with the client, especially if things change, right? Like what we were just talking about. If your client starts, you know, just showing up to your congregation, your client is now showing up to the home group that you run, your client is showing up to the recovery dinners that you have. Because things have changed, and we know that change is a constant in this world, then we just openly discuss how the changes have affected the boundaries and reassess. Is it time that I refer out? Note it in the client's chart. Always, always, always note it in the client's chart. The minute you think that there has been a boundary crossing, note it in the chart, note the conversation that was had, note the follow-up that was had. And you've got to reevaluate and document in the chart. Did the boundary crossing, did the boundary violation, well, let's stay with crossing, did the boundary crossing affect the treatment plan? Is it affecting the counseling relationship? Am I now, here's what I'm going to do as a result of the client joining the congregation, the client joining the home group, the client joining those really special recovery dinners. Preventing harm. We know as providers, every ethical decision and action has an ethical implication leading either to the benefit or to the harm, and we need to carefully consider whether decisions or actions have the potential to produce harm of a physical, psychological, financial, legal, or spiritual nature before implementing them. Again, everything that we say and our actions within that counseling provider-client relationship needs to have a clear purpose. At least that's my philosophy. It should have a clear purpose. And if not, we really need to question the motives of why we're saying or why we're doing a particular action. So what I want to do is I'm going to take a quick break, 5-minute break. We're about halfway through. So if you need to get up and take a break, go ahead and do that. What we're going to do is we're going to take some time to answer some questions. In the meantime, Robert, anything in particular that I may have missed from the chat?
I haven't seen anything. It looks like there's a couple newer questions that have come in. When does a peer support draw the line in a relationship, in a dual relationship? So I think maybe that question's asking, peer support, the lines are a little bit more blurred than clinician to individual. So that question is there.
Absolutely. And there are some really good guidelines and some good literature coming out for peer supports. This is certainly something you would want to use in your consultation with other certified peer supports. If you are hired as a peer support through an RCO, recovery community organization, that is something that they should have policies and procedures on. You know, this is roughly our expected interactions with our clients. This is where we draw the line. And that I can't speak 100% to that because I'm not a certified peer support. And while I'm trying to get them into our hospital, we don't work with them yet. So I don't know what that line is when it comes to their particular ethical guidelines. If someone does, I would love to hear their input. Yeah, so I'm not hearing much about peer specialists, so it's a little confusing. I work with people who have serious mental illness and substance use disorder, so taking them to a meeting seems a little bit iffy to me. I'm also the only one on our campus in this type of position. Yeah, absolutely. Not every not every situation is going to be the same or going to be conducive for taking someone who is in somewhere along their substance use recovery out to a meeting. I totally understand that. Yeah, you've got to do what works right for you and the agency you're with. I meet clients at a meeting. I never transport them. Yeah, I think that's I've heard that as well. Individuals who will meet them but not transport them, you know, because yeah, that puts a lot of liability on that peer support specialist or provider if you're going to have a client in your vehicle. Yes, it's a very needed position, but the role needs to be clearly defined in the process. Mary, I completely agree with you. And it's so interesting because everyone kind of has their ambiguous, nebulous idea of what a peer support is and how they want to use it. And I agree. And I don't see a clear definition quite yet. If you connect with your local RCOs, so in Pinellas County, you've got Recovery Epicenter Foundation. In Pasco, I think you have the Hope Shot. In, you know, Faces and Voices of Recovery, or, you know, tons of them across, you know, the Florida state. We're all working together to try to identify one cohesive explanation of what a peer support is, and really ensuring that peer supports don't become another clinical tool, but that it remains altruistic in nature of a peer support, being able to share their shared experience, being able to, you know, attend meetings with clients, of being able to be that person to take that phone call, you know, maybe after hours or in the morning when that client is struggling. And I think the Lutheran Services, the managing entity, I believe they have a pretty good definition of what a peer support is that seems to fit this. But that is not an adopted definition of peer support for the entire state of Florida. So it can vary, of course, depending on what region you're in. Can a certified peer support be their personal friend? That's a good question. Again, I don't know their professional boundaries and guidelines. I think if you're working in a working profession, and yeah, I'm here seeing a lot of no's, not no's, I would, yeah, it seems like that is a professional role, while the boundaries are a little bit different. Whereas maybe you know, you will have a personal phone number, or you will attend meetings together. I believe crossing that friend line is still a boundary crossing that would probably be not encouraged, especially as we're working with individuals early in recovery who are vulnerable populations. And Stacy, absolutely, yes, but boundaries need to be clearly defined. Absolutely. All right, I think we'll give it one more minute before we keep it moving. Are there any questions or feedback? So it needs to be related to recovery. Peer support, not necessarily. There is mental health peer support. There is substance use peer support. There's veteran peer support. There's kind of peer support for almost any sector that you can find, but the most talked about, the most focused on one so far, at least that I've seen, is substance use recovery peer support and mental health peer support and veteran peer support. All right, let's go ahead and get back started. So we know there are boundaries and ethics when it comes to interprofessional relationships. We need to be treating colleagues with respect and courtesy and fairness and good faith, and we'll afford the same to other professionals. In the event that somebody works for a substance use treatment center that ascribes to MAT treatment, we have to show them the same amount of respect that we do to individuals that work at a substance use treatment center that requires abstinence. There are different routes for recovery for everybody, and we need to, understand that all routes are a route to recovery, and allow that professionalism to be there. We talk about assessment, evaluation, and interpretation. So assessment instruments, they're really to be used as one component of the treatment or substance use counseling process, considering the client's personal and cultural background. Assessment is for helping to promote the well-being of the individual or client or group. It's a tool. It is supplementary to the counseling relationship. And you want to base your recommendations and reports on approved evaluation instruments and procedures. So it's important that we're not using assessments that are out of date or that we know are culturally biased. If we have the option of using and educating ourselves on up-to-date assessments and best practices, we need to be doing so. So there are outdated assessments. We want to avoid reliance on outdated or obsolete assessment instruments. We're going to seek out and engage timely training or education on administration of assessments, scoring and reporting, and testing procedures. There's tons of CEUs and opportunities to educate ourselves on updated assessments that are going to be more culturally unbiased and more specified for particular diagnoses or particular symptomology. If you think of it, think back in the 1800s, right? You might go to your local doctor, yeah, and he'll say, you have spirits, right? We're not going to use that same assessment that doctor from the 1800s was using for our clients now, right? We know there's advanced science, there's advanced symptomology, and this is actually where AI can be helpful, but we'll get into that in just a little bit. Professional competence. It's important that we stay informed regarding new information in our fields, specifically when it comes to addiction and addiction treatment. We want to attend conferences, teaching updates. There's websites with information about addiction and addiction treatment. You can go to drugabuse.gov, samhsa.gov, safordocs.org are really good resources that have up-to-date information, new research to follow. Treatment of co-occurring and mental disorders really should be integrated into addiction treatment. It's very hard to separate one from the other. Very often, mental health disorders and substance use disorders are best friends, and they often show up together. It's very rare that we find somebody who has solely a substance use disorder with absolutely zero mental health concerns or issues. So I think it's important to be open to potential other differential diagnoses. And we know that detox from drugs is really only the first step in the process. Treatment programs should assess for infectious diseases, HIV, TB, Hep B, C, syphilis. This really helps patients modify risky behaviors. So if at your facility you're doing inpatient rehab treatment, those type of things, it's important that we also have an opportunity for our clients to have their full health assessed. We know that recovery can be a long-term process with the need for repeated treatment episodes. And so we want to make sure that we're competent in understanding of what that might look like for our client and what risk and warning signs are coming up that maybe a relapse might be on the verge. So here's an example of what this might look like. You're a certified peer support specialist. You meet a new client, you introduce yourself, and the client isn't clear what your role on the treatment team is. You explain that you are like another counselor and your time together will be basically another therapy session. During one of your meetings with the client, you were asked by the counselor to update the treatment plan goals. While doing this, the client shares that they don't think the antidepressants they are prescribed is working. They share that they are still having a difficult time getting out of bed and that their anxiety seems to be worse. You tell the client they should stop taking the medication and they should start taking the medication you're prescribed because it's working well for you. Hopefully, this was a pretty clear one. This one feels like probably one of the most clear ones that we've had. You cannot, yeah, thank you. Thank you, Dan. No way, absolutely. So many things are wrong here, right? If you're unclear of what your role is, it needs to be clarified before you're working with clients. You need to know what the boundaries are within your professional role, especially working with other agencies. Cannot say this is basically another therapy session because that is leading the client astray, right? They cannot be using a peer support as a therapist. You absolutely should not be updating a treatment plan. That is not the job of a peer support specialist. That is the job of the clinician. You should not be giving medical advice. That is not the job of the peer support. That is the job of the psychiatrist. Now, if a client shares with you that they don't think that their antidepressants are working, that is certainly something you'll say, oh, okay, have you talked to your doctor about that? Have you talked to the psychiatrist about that? Have you talked to the nurse about that? Those are things you would want to respond with, not a personal recommendation on something that you're using. Now, a peer support may say, you know, I actually struggle with depression as well. I have found that for me, XYZ works. And then maybe they can have a conversation about it, but in no way should a peer support specialist be making medical recommendations. Yeah, thank you. Yeah, Mitch said, what the heck? Yeah, I know, right? I'm glad that this one was a kind of a slam dunk for everybody. So we think about counselor attributes. So the addiction professional, you know, we want to avoid any action that might appear to impose on others acceptance of their religious or spiritual, political, or other personal beliefs, while supporting participation in recovery support groups. So we want to be cognizant of ways in which the use of psychoactive chemicals in public or private might adversely affect the opinion of the public at large, the recovery community, members of the addiction treatment community, or most particularly vulnerable individuals seeking treatment for their own problematic use of psychoactive chemicals. So consider that maybe you are in a rural area or even an urban area, and you are in the substance use treatment realm. You yourself do not have a substance use disorder. And so you are out on the town, you're having a few drinks, and a client encounters you or sees you, or you're posting pictures of having some drinks, you know, on the boat over the weekend. What do you think that does to your perception in the community as a substance use provider, or your perception about, or your client's perception of you about when they might work with you next? So again, be really mindful of disclosure. We want to make sure that we're cultivating trust and empathy. If we use disclosure too liberally or inappropriately, we can remove the focus from the client and it can really derail their progress. And competency really may become a focal point issue, especially if there are 12-step beliefs or values. We want to make sure that we're not professionalizing AA. Theoretical orientations might be different from a clinician to a client, whether they want to participate in 12-step facilitation or if they want to find a different route for recovery support. And when the ability to maintain appropriate and ethical boundaries come to a forefront, that's a clear sign that you need to take a step back and address what is happening. You know, for example, if your client is interested in attending a recovery support group that maybe you've had a poor experience with and it's starting to affect your counseling relationship, make sure you're getting counseling, consultation, and supervision with this. What might this look like? You've been employed at a very busy, short-staffed treatment center for 3 years. Your annual review and client feedback has been consistently terrific. Recently, your spouse asked for a divorce, and this has thrown you for a complete loop. Your depression symptoms are worsening, you've been unable to get out of bed, and you've been late for work and haven't been eating well, not keeping up with hygiene, and have disconnected from your support group. You know you haven't been providing the best quality of care and are beginning to worry about your own recovery. What do we do in this situation? So we've got to be mindful, ask for help. Absolutely. Absolutely ask for help. Be really mindful of what's going on in your world. You're starting to notice that increased pressures are creating a vulnerability for yourself. And this is a very slippery slope. A lot of times people think, well, how could that clinician have ever crossed that boundary violation? A lot of times it's not just a few bad apples in the bunch. A lot of times it's good people with good intentions who have increasingly stressful life events that they are not managing well, pile on, and then they become more vulnerable to slipping into these patterns. So yes, get your own treatment. Self-care is always first. Take some leave. Yeah, you've always got to be open to feedback from colleagues. Maybe people might see this before you do. They might say, hey, I've noticed XYZ. And I have to believe that people have good intentions. And it's okay to take a break. We say this all the time. It's okay to not be okay. We are human beings just like everyone else. It's okay to get your own care. You can't pour from an empty cup. Absolutely, Carol. So when you think about clinicians who are also in recovery, here's what some of them are saying. This is Charles. He is 68 and he is a licensed clinical social worker. He said, there has to be a clear division, in my opinion, for somebody in the field between what they do professionally and what they do privately in their recovery. And when I come to work, I'm a professional and my recovery has nothing to do with it. So this is an interesting way to perceive how both recovery counselors and those in recovery themselves and those who are not perceive really their jobs. It was stated that it's not wise to use ethical codes as the only or final authority because circumstances really vary greatly, especially for recovering counselors when you think about those dual relationships. And he explained that, while ethical codes prohibit some behaviors, there's really complex situations when it comes to counselors in recovery, dual relationships, potentially attending the same meetings. So we've got to really make sure that we're using our moral code as well and not just strictly relying on our membership organizational ethical codes. Again, besides maintaining ethical professionalism, the recovering counselor in rural communities, especially smaller communities, may find multiple relationships with clients nearly impossible to avoid. Because substance use counselors, in comparison to other mental health counselors, have greater opportunities to interact with clients outside of therapy sessions. Counselors' recovery status may be common knowledge in the work and the recovery environments. And recovering counselors who work at substance use treatment facilities find that being a counselor actually hinders their recovery journey because many of the ethical boundary issues they encounter. And alternatively, they find that the dual status of being both a professional substance use practitioner and a 12-step member, some of them find it as an asset. So it's really 50-50. Some people struggle with it. Some people find it an asset. So there's a clear need for additional guidance for substance use professionals who are also in recovery outside of strictly the ethical standards by our memberships. Carolyn, she is 63 and she's a licensed mental health counselor. I couldn't leave it at the door. I mean, it's just a part of me. It's like, who am I? Excuse me, it's like who I am and who I'm striving to be. It's not like I'm one person at work and another person somewhere else. I mean, yeah, my job is important and it has certain guidelines and boundaries, but everything in my recovery touches every aspect of my life because recovery is the most important thing in my life. So it's important for me to do my best, to live by the principles and the steps. So you can see how very clearly different two professionals with two very set guidelines from their membership organizations are viewing those dual relationships and their own recovery. So when we talk about legal and ethical standards, we've got to be fully cognizant that of all the federal laws and the laws that govern the practice of substance use disorder counseling in their respective states. Each state has potentially different laws. Obviously, CFR 42 Part 2 is a federal law, but there are some states that even go above and beyond for substance use protections above the federal law. So that is something interesting to keep in mind. We want to strive to uphold not just the letter of the law, but the code and aspirational standards, autonomy, beneficence, you know what I mean? Beneficence. This is embarrassing. Beneficence, such a hard word for me. Non-malfeasance, justice, fidelity, and veracity. So we know that there's undoubtedly gray areas in cases, especially regarding concepts of capacity and reasonable cause. So let's look at Patty. She's a licensed clinical social worker who's also in recovery, and she attends AA in the community as a part of her recovery. She sponsors an individual she meets at the AA meeting. This individual is not a former or current client. During the 5th step, responsee discloses they harmed a child in the past while under the influence. Does Patty have an obligation to report the disclosure? Report. All right. So regarding a duty to warn, counselors might be faced with this moral dilemma. So if they sponsor an individual outside of their professional work who discloses to the counselor that he or she plans to hurt someone, the Supreme Court has actually found that agencies are not guilty of failing to warn when there was no patient or professional relationship. Therefore, a professional is not mandated to warn if they are not in a professional relationship with the individual who threatens to harm. Although counselors in this situation may warn if they choose to do so. So this situation is a little bit different, but it seems to say that, well, it's not a professional relationship. You are in you're acting as a sponsor, not as a licensed clinician. So yeah, you're absolutely, it is a moral decision. Do you report? Do you not report? The Supreme Court, it looks like, would be supportive of not if you felt so inclined not to do so. However, but all people are mandated, right? No, not all people are mandated, right? So under your guideline, peer supports, is that a legal mandate? Are they mandated reporters? I don't know the answer to that. I can speak from my profession, clinical social workers, clinical therapists. Yes. Oh, Carol's saying yes, that they are mandated reporters. We are mandated reporters. However, if we're not working in our professional role at the time that we're hearing this information, does that make you a mandated reporter at that time because you're not technically in that professional relationship? And I agree that I would say it's a moral choice at that point. I probably would choose then to report just to make sure that I would feel good about it, especially knowing if it was a child. I believe that should absolutely be reported. And especially knowing that you can always make reports doesn't mean it'll ever be substantiated. And in Florida, all adults are mandated reporters. Oh, that's interesting. Oh, the hat is always on. So right, yeah, I think it's interesting. It looks like the Supreme Court would say, well, the agency didn't fail here, right? Because they weren't in a professional relationship. But I would agree. I think this is moral, and I think this is something that I would do as a clinician, as a mandated reporter. But again, another opportunity to kind of have that thought experiment and say, well, what would I do in this situation? And again, if you don't know, consultation, supervision. We talk with other professionals. We talk about these things. That's why we have consultation and supervision available. And yeah, you can absolutely report anonymously. So we're going to talk about e-therapy and e-supervision. So a technology-based informed consent discussions. We want to make sure that at the start of e-therapy, it's not always appropriate to substitute or replace face-to-face counseling for interventions. You've got to be really mindful that is virtual services appropriate? Is virtual supervision appropriate? Again, duty to warn, mandated reporting laws apply to all counseling services, including e-therapy. So obviously your virtual therapy, you are still under that guide. You're still a mandated reporter, even with virtual therapy. And it's really important to be informed about confidentiality, privacy rules, laws, and exceptions under those rules and laws. So as addiction professionals, we are absolutely witnessing an expansion of available technologies that offer opportunities for electronic and distance delivery of care. I believe Florida is a part of the compact, so we can practice across state lines. It's incredibly important that we know where those emergency services are, where our clients physically are in the event that we do have an emergency. We want to make sure that we are prepared. Obviously, there are really great benefits to using telehealth for counseling services and substance use treatment. It really reduces the geographical barriers. You can provide services to those with physical inabilities to get to your facility. We work with individuals and families who would not maybe take advantage of traditional services. There's obviously limitations, right? There's concerns about maintaining confidentiality. I can't tell who's in the room all the time, or I can't tell if, maybe somebody is able to hear us, or, this is technically, are you in a confidential space? And Dan, I agree, 80% of communication is body language. So we miss out on those subtle cues. We miss out on the energy. We miss out on, a lot of those body language responses, those really specific facial movements. But it also gives you an interesting insight into that client's world, right? So there are pros, there are cons. You've just got to be mindful that you're doing what's best for your client and it's fitting the client's best needs. So if you're starting teletherapy, you want to make sure that there's a policy. I need my clients to know if they email, if they text, if they chat, what is the response time, what is appropriate and what's inappropriate, what will text be used for, what will email be used for, what will chats be used for, what will only be happening in individual one-on-one conversation. These boundaries need to be set up ahead of time, and they need to be thought about before you start with telehealth with a client. So make sure you have these policies in place and be mindful. So some insurance policies are not covering telehealth for services. So always make sure that you're not setting your clients up for something that's going to cause a financial burden for them. And do you have a social media policy? This is something to think about. What this might look like. So Kai is a substance use counselor. She's working with a client who is a straight single male. During their online sessions, he notices photos of her with her children on the wall behind her. He also notices no photographs except those of her and her children. He assumes she's single and begins to flirt with Kaya during sessions, which she deflects by changing the subject and shifting the conversation. When his advances fail, he contacts her outside of office hours through direct messaging. He calls for an emergency session, saying he's struggling and he needs immediate support. Kaya receives the message late in the evening. She considers referring him to the emergency line or other more appropriate resource, but his message is insistent, so she decides to meet virtually that evening. When the virtual visit starts, he admits that his motives for calling the emergency session are because he misses her and he needs to see her. Kaya realizes there is no crisis, so she reminds him that she is his counselor and is responding to the situation he has conveyed. He gets angry, accuses her of coming on to him, and leaves the session. What do we do in this situation? Now, there might be a couple of different answers of what you do in the situation, but I think it's really important. And what this highlights is that if you're doing telehealth, stage your professional space mindfully, right? Think of the space that you're using for virtual visits. What is in frame? What can people see, or what can they learn about you from maybe what's behind you? Are you remembering to blur your background? Do you want to blur your background? Do you have personal information that maybe your clients can glean from the environment visible? So potentially she could have staged better by ensuring her space didn't show personal photographs. Remember, what you show on client is really what you show on camera gives your client a glimpse into your world. So you want to make sure that it's only professional. And you want to openly address inappropriate behavior. When a client behaves inappropriately, it really becomes our responsibility to address the behavior. This is where education is really crucial. It lays the groundwork for potentially challenging conversations. If she had laid the groundwork for expectations with tools, she could address the client's unwanted advances and say, hey, remember, we went through this policy. It's right here. You signed off on it. This is inappropriate. And then here are the consequences that were obviously pre-thought of and in policy. When a professional boundary is crossed, it's really critical to address it openly. For example, she could have initiated a professional conversation instead of ignoring her client's flirtatious behavior from the beginning. If addressing her client's behavior became too uncomfortable or challenging, she could really contact her colleagues for supervision and support. This is an example of why it's so important to not let little things slide in that counseling professional relationship and address them regardless of how uncomfortable it is, and always use your supervision and your peers and your colleagues for consultation. You can always use your professional membership organization as well. They have lines that you can call to really discuss ethical considerations and maybe hypothetical situations if you're looking for guidance. So if you think about telehealth and e-therapy, in addition to doing what you can to protect your own boundaries, make sure you're doing the same for your clients. Your clients deserve a remote therapy experience that looks and sounds and feels professional, even if it's not a face-to-face session. So you want to make sure that you're in a private space, that you're being really mindful of who can hear that conversation or who cannot hear it. So artificial intelligence, this is a really interesting one. We know that addiction professionals who use or are contemplating using AI face numerous ethical considerations to be assessed and addressed, which is related to informed consent, autonomy, privacy, confidentiality, transparency, potential misdiagnoses, client abandonment, surveillance, bias in the algorithm. And this could, artificial intelligence in itself could really be an entire presentation. So just briefly, we can talk about, There is a future in which AI definitely plays a meaningful role in mental health and substance use treatment. But right now, there are absolutely no AI chatbots that have been FDA approved to diagnose, to treat, or cure a mental health disorder. There are several companies that have designed products to improve well-being based on psychological expertise. So Woebot, it's WOEBOT, for example, it doesn't use generative AI, but it draws on predefined responses approved by clinicians to help people manage stress, sleep, and other conditions. So it's not generative AI. There are really some things to be mindful of. If we want to talk to our clients about using AI, we need them to know that there's very little regulation that exists in this space right now. Chatbots are designed for entertainment. They're not grounded in peer-reviewed, clinical, rigorous tested assessment or risk. And with a user who may have a mental health concern, the results that you're getting from chatbot can be really unpredictable. And so if we want to even talk to our clients and say, look, you know that you're engaging with AI rather than a human, sometimes this isn't enough to prevent harm. So chatbots are really pithy and conversational, and they speak in a very matter-of-fact way. And it can give the illusion that I'm giving you reliable insight and I'm giving you deep insight, and it is accurate because the way it presents. And this illusion is really hard to break once it's cast. And so it can be really dangerous for people who are particularly vulnerable. When we talk to other people, and it was brought up earlier, we miss those subtle, or we pick up on those subtle cues. We get the body language. We can really sense that energy. We pick the very, very subtle eye movements. And those are things that we can naturally attune to regularly, where obviously a chatbot or AI is not going to notice any of this. They have no knowledge of what this would even be. And so they don't know how to incorporate different perspectives. They don't know how to not jump to conclusions. And they don't know how to gently challenge harmful thoughts and beliefs. It's really interesting because the goal of chatbots is to keep the user engaged for as long as possible, so their data can be mined for profit. That is what it is for. And they can give us really convincing impressions about being caring and intelligent human beings, but they're not trained therapists. They tend to repeatedly affirm the user's perspective. So they could potentially be affirming really harmful or misguided ideas. So it's incredibly important to be mindful. While AI has some incredible potential, it could really be helping us with analyzing vast amounts of data, or helping with our treatment planning, or helping identify differential diagnoses or targeted goals. We can help in documentation, early detection and prevention. We want to make sure that we're not encouraging AI chatbots specifically for any sort of therapeutic replacement. So social media, professional literature does not exist to the extent that it does in other areas when it comes to social media boundaries and ethics. So we just know, clients have Googled us. Clients have said, oh, I looked you up before I came in here, or I saw you on LinkedIn, that type of thing. So be mindful. What do you want to have available for clients to see? If you're going to have social media, is it a professional account or is it a personal account? Do you have two separate accounts? Are they linked? Are you able to find one another? So it's important to make sure that your professional and personal digital life are very separate. So what this might look like, so you're meeting with a client, and at the close of your session, the client pulls out their phone and starts showing you pictures posted to their Instagram from their graduation. You ooh and ah over the photos and congratulate them on their achievement. The client mentions that they've looked you up on Instagram and said, you should follow me. So I think this is pretty straight and clear, professional boundaries, absolutely not. I don't engage with clients. Social media is private. No, thank you. It's a conversation to have. Again, don't accept clients from your friends, don't accept friend requests from your clients. Really, if you're going to have social media, do have a separate professional and private one. And respect the patients' privacy, don't ever look them up on social media. And then know your own privacy settings. Know who can access your information and who can't. You want to make sure that you discuss, even with your initial sessions, and colleagues. Do you want to friend and connect with colleagues? Do you not? Do you have boundaries with your coworkers or with your, do you only connect professionally on your social media, or do you blend your personal and professional social media friend connections? It's just something to have in mind in order to keep your boundaries in place. So we know that if we come across an impaired practitioner, we want to make sure that we're informing consumers, termination of services in writing. You want to terminate in an appropriate manner. You want to assist in referrals to other referral source treatments and take immediate steps to address the impairment through professional assistance. So how do we address ethical concerns? You want to behave in accordance with legal and ethical and moral standards for your work. And attempt to resolve any ethical dilemmas with direct and open communication involving all parties. If you see a colleague and you feel that their work or their engagement is starting to cross the line of a boundary violation, you just want to have that conversation with them, bring them in, be open about it. Have they engaged in their own therapy? Are they working on their own stuff? It's important to know, what do I need to manage of my own to make sure I don't impact or have transference for my client or onto my client? What sort of aspects of my personality are triggered by my work, right? So how well do I know myself to know where my vulnerabilities are? So we're going to skip over a couple of these because I know I'm running short on time. But you will all get a copy of this presentation. Those were just a couple of examples. So when you confront colleagues, if they've been negligent, they show an inability to practice safely, if they violated any ethical codes for some reasons, you want to make sure that your professional boundaries in the treatment settings are in place. Are you following the policies and procedures that are set in place by your agency? And treatment providers have an obligation to establish and maintain clear and consistent boundaries. Boundaries are the therapeutic frame, and boundaries are determined by our role, our context, our practice, and our contract, right? So a therapist, a psychiatrist's boundaries are going to be a little bit different than a peer support's boundaries. So it's important to know your role and where those boundaries end or begin. And if you're in recovery, understand that maybe attending fewer or different meetings might be something that you'll have to do at some point. You might end up having a smaller circle of friends or a close recovery support versus a large recovery support in order to keep those professional boundaries as a helping professional. You might feel some discomfort at meetings. You might keep an emotional distance in meetings. You might feel less likely to share the difficulties or cravings in meetings because you want to remain and keep that professional boundary with a potential client or a client that is at that same meeting. And we find that counselors in recovery often tend to sponsor others less, really as an ability to withhold those and keep those boundaries. Blurry boundaries that give others messages that it's okay to violate your boundaries. This might be being too responsible for others. That can lead to burnout, too much empathy. So you're taking on the moods and feelings of others. Pleasing, having a victim role, sacrificing. This is really often going to lead to resentment and more invalidation. So if you're starting to see any of these signs or symptoms, these boundaries might be getting blurry for you. Are you saying yes, always volunteering, feeling obligated to say yes? Are you not expressing your wants, your preferences, your needs? Or are you overstepping others' boundaries? Again, this is just a reiteration of what a boundary crossing and what a boundary violation is. A boundary crossing may have some benefit or have a positive intention, where a boundary violation is harmful and ill-willed. Boundary violations are avoidable, dual or multiple relationships, obviously sexual relationships, personalization of care, right? That's not person-centered care. So you can always ask yourself, if you're questioning, have I made this about me in any way? And that's a good way to see where you are with maybe a potential boundary crossing or a boundary violation. What is the most common complaint brought before the social work credentialing board? sexual relationships with clients or former clients. Situational factors and life crises combined with professional isolation can lead to providers attempting to get their needs met within the provider-client relationship. Having a place to process feelings of sexual attraction with a trusted colleague can help minimize professional isolation and bring a level of accountability that might not be present otherwise. So you want to make sure that you have counseling supervision, that you're taking care of yourself so your vulnerabilities don't lead you to a place where you're trying to get your needs met from your clients. So as a provider, these characteristics may be a personal boundary violation if you're trying to instill guilt, name calling, yelling, sarcasm. If the counselor is starting to treat others as inferior, if they're taking over conversations, if they're mocking. These might be signs you see within colleagues: excessive teasing, condescending, breaking confidence, demanding, withholding. Definitely some warning signs to be mindful of. So our vulnerabilities could be illness, could be physical challenges, relationship struggles, life crisis, professional insecurities, loneliness, and then just neglecting to work on our own issues. So if you're making recommendations outside of your scope of practice, that might be a warning sign. If you're enabling, wishing you could rescue your clients, if you're being attracted or being more attentive to your appearance when you know that you're going to be seeing particular clients. And personal boundaries, you want to set physical boundaries, personal boundaries. These are things that should all be addressed before before you start counseling. Again, in any way are you making this about you would be a really great way to potentially guide any concerns. So some do's and don'ts for addictions professionals: always focus on the client, right? Keep in the back of your mind, am I making this about me? Number 2, don't fall in love. There is no place for love in an ethical client-professional relationship. If you feel yourself developing feelings, address it immediately, refer the client out. And make sure that you always have your client in focus and in the right professional light. Don't fall in like, right? Be mindful. You don't want to engage or solicit any sexual contact. You want to uphold a boundary for 5 years after counseling, or your consultation relationship has ended. For some organizations, it's 7. For some organizations, it's never. You want to look looking beyond the 5-year rule. Again, our everyday interactions aren't with everyday people. We are building relationships with individuals who need our professional help. We want to understand and keep in mind that these are power dynamics, and we are working with individuals usually at a really vulnerable time in their life. Transference and counter-transference, obviously something that you want to be mindful of. Make sure you know what you're bringing into the sessions. Let's see, CDPs, 54-year-old licensed marriage and family therapist. I find myself at times relating too readily to the clients and their early recovery. If I share too much, that is a boundary issue, because sometimes the clients will then relate to me as their friend rather than their therapist. So this is an example of where oversharing and over self-disclosure can work against you. So on a scale from 0 to 10, how important is trust? It's a 10. It's what builds that relationship. So how do we address ethical decision making, right? You want to identify the problem. You want to collect the facts, explore the options, weigh the options, decide on an action, and reflect on the outcome. You know, it's the viable ethical decision-making model. You want to incorporate supervision and consultation regarding your concern. Consider relevant ethical standards. Is there a precedent for this? What are possible courses of action? You want to generate all the possible courses of action, deliberate the risks and benefits of each potential course of action. And then you have to act. You've got to select one. You want to make a decision based on the circumstances and the welfare of everyone involved. And you want to reflect upon and redirect if necessary after implementing the decision. So although ethical issues are usually complex enough to require a case-by-case evaluation, agency practices really should provide a routine process for approaching an ethical issue. So what are the clinical needs of the client, and how does the ethical dilemma relate to what the client presented with initially? So review what the principles are at stake, right? What is the true dilemma? What harm is being done either by the client or to the client? Can the client make their own decisions, and are they not being allowed to do so? Is the client being treated fairly regardless of race, culture, or lifestyle? And is there a threat to the client's confidentiality? You want to review the pros and cons and act, follow up and evaluate. Was the choice we made, did it turn out to be the best choice? Would we have done something different? Will we do something different in the future, or will we do this again if it were to come up? So education, self-care, self-awareness, monitoring, peer debriefing, consultation, supervision, these are all really important things to help make sure that you're staying within your ethical and moral boundaries and guidelines. So 3 steps to remember: always maintain professional conduct, document and report it the minute you notice that there's a boundary crossing or violation, and always debrief. Debrief with your client. Oh, I probably shouldn't have said that. I realized I crossed a boundary when I said that. Let's talk about it. I'm going to document it. Should we be doing anything different moving forward? I'll be mindful XYZ and bring it up. So in conclusion, I do want to leave you with this. We counselors have a lot of power. As authorities on this terrible disease of addiction, let us be careful to never use power for petty or vindictive ends, to never thoughtlessly reject a client. We can affirm our client's sense of value, or we can damage them with a casual joke or a comment at their expense. We can help them to respect themselves, or we can tear down their good or great harm. Or we can tear down their self-esteem by treating them disrespectfully and unimportant. We have the power to do great good or great harm. Today, let me remember my power and take care to use it wisely. And then at the end of the slide deck, there are some resources that you can use, a couple of local relevant resources and a couple of book recommendations. And that is it. I know that we are out of time, so I know a lot of you will have to jump off, but I'm happy to stay if there's some questions.
Thank you, Amanda. I'm going to take over and switch to conclusion. I know we do have, we are a little over time, so I'm going to go through this just real quick. I know those last few slides we moved pretty quickly through.
I'm sorry.
No, you're okay. I put the PowerPoint in the chat, ladies and gentlemen. Those last few slides are there. 84 to 94 is that ethical decision-making process that many of you were asking about. I will make sure to post that again in a moment. I know it's getting kind of lost in the thank you, so I will post that again momentarily. Amanda, thank you for your time. Thank you for this information. It's always great to have so many questions to have to answer. I think that's a really great problem to have. This was a very practical training. So I'm going to go through this real quick. Everyone, I've posted the link to the evaluation in the chat. Again, I will post it here in just a moment. Additionally, when I end this webinar, your web browser should populate a message that looks like this. It says the host or presenter would like WebEx meetings to open a website on your computer. If you click continue, it should automatically redirect you to the evaluation. You must sign into your account to complete the evaluation. If you do not have an account with us, you can register for one at no cost by clicking haven't registered yet under the sign in menu. Please use the same email address you used when you registered for today's webinar when you set up your profile in FATA system. This is the only way for us to connect your attendance to your evaluation completion. For CEUs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking edit on the professional information section of your profile. You'll get a third opportunity to complete the evaluation through a follow-up email later today. The evaluation will close on Thursday, May 29th. For assistance with account login, account registration, or evaluation completion, fill out a contact us form on our website or email the training team at training@floridabha.org. As a reminder, we do not email statements of credit, Instead, once we verify attendance and evaluation completion, a statement of credit will be posted to the professional development section of your profile within 30 business days. You must have attended the entire webinar as well as completed the evaluation. We are not permitted to provide partial credit. The recording and materials used in today's presentation will be available on our website within 30 business days. If you visit www.fata.org, navigate to the Resource Center and click on Training Library as shown on the screen, you can access the recording and PowerPoint. Thank you everyone for participating in today's webinar. We'd like to thank Amanda again for your time and information. We'd like to thank the Florida Department of Children and Families for funding today's education. Have a great day, everyone. Please hold for the evaluation.